So it's very important for us to know that as well. It can identify specific antibodies, and it's used to monitor myeloma treatment specifically, and looking at the level of the myeloma antibody. Serum-free light chain analysis. I talked a little bit about the danger of the free light chains, and particularly what they can do to your kidneys, and they increase blood viscosity and all of those things. This measures the amount of free light chain, kappa and lambda, that is in the blood, as well as the kappa-lambda ratio. We all have these. We all have kappa and lambda. And they should be in a similar ratio in the body. So they may get very out of whack in someone that has myeloma. And again, it's used to diagnose and monitor and evaluate. For us, the type of problems that we see in the kidneys are a little different, actually, down the road with lambda as opposed to kappa. So it will also guide us into sort of what to be watching for down the road. And everyone's favorite, a bone marrow biopsy. I know, I wish there was another way to do it, believe me. We all wish there was another way to do it. But because it takes 26 to 28 days to kick a red cell out of the marrow into the peripheral blood where we can measure it, it's really important for us to be able to actually see what's going on in the marrow. It gives us a real-time picture. Everything in the bloodstream is what happened in the marrow, like so last season. We need to know kind of what's going on there right now, because that's when we can intervene and begin to change the things ultimately that are happening there. So samples are found in the bone marrow. I'm sure you've all heard the term stem cell. So the stem cell is the one we call pluripotent cell, from which all cell lines come. That's all it is. There's nothing, exotic, but that is where platelets, red cells, white cells all come from. So people will say, I had a stem cell transplant or I had a bone marrow transplant. The truth is, in the old days, which was like 10 years ago, everybody got bone marrow because it's the only way we knew how to do them. We took bone marrow out, we gave everybody bone marrow. That's what we did. But what we wanted out of the bone marrow was the stem cells. We didn't want all that other stuff. We wanted the stem cells. Now we've learned ways to be able to get stem cells a different way. But stem cells are the most important thing in terms of the cell from which all cell lines are going to come out of. I'm sure you all know we use a needle, and it's a rather large one. It goes into the posterior hip. We pull a small amount of marrow, a small piece of the bone. And what it tells us is exactly what's going on in the marrow, not only the percentage of plasma cells, and if you have an anemia, what I want to see in the bone marrow is, are there baby red cells there, or didn't they even get there yet? If your platelets are low, is it something that happened between the bone marrow and getting out into the peripheral blood, or are there no baby platelets in the bone marrow? So it's very important for us to do. I think for anyone, I know one person said she'd had a transplant. If anyone else has had a transplant, we don't check bone marrows immediately after transplant because it takes a while for the full effect of the treatment. We usually wait about 60 days.
I have another question about the bone marrow biopsy.
Mm-hmm.
It would stand to reason that your bone marrow biopsy, your bone marrow would be sort of the same all the way through your body, but I understand that it's not. So can you address that a little bit?
That's a really good question. Anytime you take any piece of tissue out of anything, no matter where it is, a lung biopsy, a bone marrow biopsy, a breast biopsy, a prostate biopsy, You're biopsying, you know, a little teeny core that's about this big and, you know, the size of pencil lead. We are imagining that that is giving us the picture in time of the whole picture, which we understand it is a sample. We hope that sample actually represents everything that's going on. But if somebody has like a smoldering myeloma or something, a smoldering meaning it's really not growing, it's not moving, it's not changing, there's sort of borderline, it's very possible when we draw it out, they lay it out on slides. You don't know how many cells you have. You're not going to know until they read it and see how many cells, good cell lines they can look at. They may say, we had 8 good cell lines to look at. And in those 8 good cell lines, we saw 1% plasma cells. But if you took a much larger sample, it may be that the person had more or less. There's a margin of error with bone marrow biopsies as with anything else. It's a really good question. It does generally give us a very good idea of what's going on, but there are those few instances, especially if the sample itself, you're not going to want to hear this, but when you take out bone marrow, there is sort of a specific way to take it out, and there's a specific place in the bone that it's found. If you take it sort of from the middle of the bone and take too much at one time, what we end up with is a lot of what we call peripheral blood. It doesn't have the actual bone marrow components in it. So it depends on how many really good cell lines came out in that sample. And you know, we have to send samples for so many things, and you can only take so much marrow out in one draw, that it makes it a little difficult. Yes?
And the doctor was reading the results, and he said, "Oh, it looks like your marrow is like blood." What would that mean?
You said it looks like your marrow's like what? You sure you got marrow? I don't know who your doctor is, but I don't know what, well, okay. If you had some patients, I will tell you, in certain diagnoses, generally not myeloma, usually myelodysplastic syndromes, it's very, very hard to get the marrow out. You may not be able to get the marrow out. And if someone's marrow is what we call packed, like you have a lot of plasma cells in there, it's very hard to draw the marrow out. Was it that he had a difficult time, he or she had a difficult time drawing it, or?
She had to go in several times because the bones kept crumbling.
Okay. I will tell you when I first learned to do bone marrow biopsies, many years ago, you don't teach people how to do biopsies on someone with myeloma. I'll tell you that, number one. Teach it on a leukemic. They have nice strong bones. Some myeloma patients, the outer core of the bone can be so soft it's difficult to actually draw it up into the syringe. You have to sort of, it's not like you're going through a hard bone to get to the marrow. Some of the bone can be very spongy, and some can have a lot of holes in it because there are a lot of lytic lesions in that area.
Are there any guided biopsies? I've never seen it. But if she has a problem like with her bone, she could request one?
Yeah, well, you know, they generally don't do CT-guided biopsies on people with myeloma, but in bone marrow, you know, it is a blind procedure. We know where we're going, but it is a blind procedure. If you had to be stuck several times, though, I would ask for sedation. My docs hate when I tell my patients that, but you know, they can be done under sedation. I just don't really think there are any extra points for suffering. So I just don't. And I think you suffer enough. So I give people drugs. That's what it's on film. I do. Yeah, I do. And when I use the Novocaine, the lidocaine, I'm very generous with the lidocaine in the bone. And just like when you go to the dentist, it's the same lidocaine that we're using. You know, they shoot your mouth, and then they walk out of the room, they wait a few minutes, and they wait until you're done before they come back. And I see people do marrows all the time, and as soon as they pull out the lidocaine needle, they shove the Gemchidi in there. You know, just give it a minute. I generally rub it in and wait a minute, but then when one of the docs I work with do one after me and the patients say, aren't you going to rub my butt? They're like, Tina had rubbed in your marrow. No, I'm not going to rub your butt. So just, you know, take a breath. Tell them just take a breath. Wait a minute. Let it get numb. And I will ask, you know, is it numb here? You know, be active about it and say, you know what, it's not numb there. So either give me more medication or move it to an area that's numb. Because really, there are no extra points for suffering. Really, there aren't. But if you guide the person and say, no, it's not numb there, they're not going to go on going in anyways. They'll go, okay. But if you don't say anything, they'll just go in. I would say, really, to be active about it. I certainly would be. You know, I tell my docs all the time, I'd be happy to do one on you anytime. When you tell patients this isn't going to hurt. I'm like, really? Really? They say that when you're having a kid. It's not going to hurt. So I have one. No, honestly. So very good questions, but be actively involved and say, no, that's not working for me. That really hurts. Because they really don't need to hurt. The truth is, you'll feel pressure going in. You should feel pressure, not pain. The one thing that we cannot numb, I don't care what anyone tells you, is the sucking up of the marrow. That part cannot be numbed. And if that part really hurts you, ask for drugs. Before. Before. City of Hope actually, we do propofol sedation. If somebody's had a really bad time, I have absolutely no interest in torturing someone. If they've had a really bad experience in the past, more than happy to have people be sedated for it. It's very fast. Okay, so tests for chromosome abnormalities. You know, in the past, in the old days, we really weren't able to very, very specifically identify a lot of the chromosome abnormalities that people had. And now, we really can. We really have gotten so much better at it. It is important for many reasons. What we call sort of high-risk myeloma, some of the translocations or deletions might lead us down a different course. In some of our patients post-transplant, someone who's very high risk, and we were talking about, you know, whether or not you give drug after transplant. In patients, some patients with high risk, and actually many of our patients do actually end up going on maintenance therapy after transplant. And it's very nice to know what the cytogenetic abnormalities were going in before you choose a therapy to continue with. It actually is very, very important. So there's karyotyping, which a bone marrow sample is taken. They look at the plasma cells, they stain them, and they photograph them, and they look at the abnormal numbers. And then there's FISH. And FISH, I mean, you know, you may think, well, you know, my doctor never did a FISH. They did. But it's not something we'd ask you about, because it's done on your bone marrow. So what FISH is fluorescence in situ hybridization. It's just a different way of looking at the abnormality, but it's very specific. So it takes a single abnormal DNA strand. So the first time I'm doing a marrow on someone with myeloma, it's going to do FISH with all of what are very well-known, similar kinds of abnormalities that you would see in someone with myeloma. And they take that probe and they dye it with fluorescent dye, and that abnormal DNA strand, called the probe, is put back in with the sample, and it will bind with alike abnormalities in the sample. So it's very specific to very specific DNA changes in the cell. And FISH is kind of, our standard. It's the most sensitive. It's the standard for looking at cytogenetic abnormalities. And again, we just do that in the marrow. I think I said this already. Keep in mind that normal varies from person to person, and normal varies from different labs. Normal varies by your state of hydration, and 24-hour protein, looking at 24-hour urine proteins, it does make a difference if you dumped that sample at the mall. And you may end up looking a little worse off than you really are. If it's a 24-hour specimen, if you messed it up, really just say, look, I messed that one up, give me another one. We have people who do not have enough of a glomerular filtration rate to actually get a transplant, and they'll go home and hydrate, and then they pass. Hydration is very important. I want to add something to that. I know swelling is a problem. Swelling, especially in the feet and legs. Our reflex response isn't always to just give Lasix or Bumex. And it's not because we want you to be uncomfortable. It's because all diuretics affect the kidneys. And they affect them in a negative way. So we have to weigh the balance of someone who consistently has a lot of swelling between the negative effects of us taxing the kidneys all the time to get the swelling out. Yes?
Are you trying to sound like water pills is a bad thing for kidneys?
They are not without consequence. That is what I'm saying.
What kind of damage would you be looking at?
Well, if somebody has, and actually you may be able to answer this better than myself, it depends on what kind of damage you have in the kidneys. If you don't have a lot of kidney damage, we still, even in my transplant patients that have absolutely perfect renal function, we are cautious with diuretics because over time they do end up causing problems with the kidneys. And do you want to add anything?
Well, yeah, the way diuretics work in the body, they signal your kidneys to release more fluid.
Right.
So anytime you're turning on that switch, it's like flexing a muscle. So eventually the kidneys will start to tire out. That muscle gets worn out, so to speak. So long term, it can cause damage, and your kidneys wear out, and then they just don't want to work the same. You do want to take a careful balance between when you use them and when you don't.
And is that specific to multiple myeloma, or is that for even a normal?
Even for a normal person.
Everybody.
Yeah.
Everyone. But the consequences can be much more rapid and severe in someone with myeloma because you already have things in your body that are taxing the kidneys.
I've read up on multiple myeloma, but this is the first time I ever heard about Lasix and kidney damage combined with multiple. I haven't read that yet, so it's kind of...
Yeah, we're cautious with diuretics. And, many people are on them, but again, we have to weigh the risk versus the benefit. If it's something that's going to make someone more mobile and they've got great kidney function and they're able to recapture their electrolytes, but electrolytes get depleted as well with diuretics. It's not something without consequence. We are cautious, and particularly in our patients with myeloma.
What would be a high number of Lasix? What would you consider a high amount taken?
Oh, it depends on the person and their kidney function. You mean daily?
Yeah.
Is it like daily Lasix? I know 40 would be kind of high for
It really depends on the
us.
individual person.
Yeah.
It really does.
Me again. I've been fortunate to only need 2 biopsies.
Oh, good.
The first one was 90% monoclonal,
Mm-hmm.
and then the second one was 1% polyclonal. And the doctors were all excited. What's the difference? What's a polyclonal and monoclonal?
I think that they switched. The 99% monoclonal was 1% polyclonal. And a 1% polyclonal would be, polyclonal just means that plasma cell is making all of the kinds of immunoglobulins it needs to make. The monoclonal one is the one that's making the abnormal M protein. A polyclonal is what you want. Monoclonal is what we don't want,
So you said
basically.
1%.
So I think they were confused. He probably said, the last one was probably that it was 1% monoclonal.
No, it was written writing, so it was.
It said 1% polyclonal? Yeah, that sounds like a typo. Polyclonal is all of the clones. Monoclonal is what we don't want. But if they were excited about it, then I'm excited about it.
Because that
And you should be excited about it.
That would mean it was 99% monoclonal if it was 1% polyclonal, right?
Right. Yeah, because it's either monoclonal or polyclonal. And they both exist in the same sample, but one percentages of one and one of the other. But, you know, it may have been fish, it may have been something else. Well, celebrate it anyways. They're happy. Go for it. Be happy. And again, you know, assessments and discussions with your clinician, we really encourage those things. I love working with myeloma. I love the community of people. I think you are, you're the smartest ones. You are. You're the most educated, you are the most involved people, and this is really why a very big part of why the future does look so bright. Because it's really you taking a response and being able to say to your clinician, wait a second, I have a question, or, you know, what about this? Remember to tell us things like peripheral neuropathy. Sometimes I'll get a patient and they've been being followed by someone for years, and I get them and they have horrible neuropathy. And I say, what were you doing before? You know, we really quit talking about it. Don't quit talking about it. It's really important that you don't quit talking about it. If peripheral neuropathy gets worse, it's important to let your clinician know, because it may direct our course of treatment. And I know frequently people go, I don't want to say anything because they're going to stop the drug. You know, sometimes it's the best thing to do. Sometimes it's just that we're going to dose reduce it. And sometimes it's that, you know, depending on the clinician, we're going to be able to look at things and say, well, let's look at what we can give you to help with that. Nutritionally, vitamins, let's make sure you're not taking anything else that can interfere with this, etc. Do keep talking about the side effects that you have. If you have nausea, vomiting, diarrhea, there are no extra points for suffering. Try. Sometimes we just forget to ask, and if no one tells us, we go, well, they must be comfortable. So please keep talking, make us address all of the things that are a concern to you. Make your clinician address them. Tell them I said so. No, don't tell us. We got to this end too. She said, you need to pay attention to what I said.
I had a question earlier on anemia.
Uh-huh.
When I was talking to my daughter about it, she goes, Dad, take a bunch of iron pills to increase all your blood. And I didn't do it because the doctor didn't tell me to do it, but I thought about it. And well, that makes sense to make the cells healthier, or get more red cells or something. So,
That is an excellent question. And I'm so glad you brought it up because we don't address it here, but we should. Iron is not a panacea. If you're iron deficient, meaning generally you're a young woman having menstrual periods, iron is helpful. Our patients, what we see frequently is the opposite. We see iron overload. People who need transfusions, become transfusion dependent, frequently will have iron overload. And iron overload is actually a negative prognostic indicator for many cancers. So you do not, that is an excellent question. And you know what? That would be a great lab We forget about these things because, we get focused on the myeloma and we do all of these myeloma-specific things, but rarely does anybody do like iron testing, which really you need a serum iron, you need a ferritin, because ferritin are your iron stores. And by the time the ferritin's depleted, you have like no iron. But our patients are in the other end of the spectrum and we have to actually give them iron chelating agents to get the iron out of their body because it can really damage the liver. And it's an excellent question.
One more and then I'll stop.
Oh no, you can ask all the questions, you know what? As long as I'm not going over, taking up anybody's time, I'll answer anything you'd like to know.
Okay, this was a really helpful presentation.
Good.
And I wondered, is it available anywhere specifically?
Well, you know what? First of all, I was going to end with this, but I want to say now, thank you to Millennium for having us and bringing me here, and Heather Bogart, who is wonderful. And Heather is very dedicated to myeloma and very dedicated to all of the support groups, has multiple resources available. There are some here, if you go to this multiplemyeloma.com, it will have some information about many different things. The IMF website, which I'm sure you're all pretty familiar with, the International Myeloma Foundation, they have information on there on lab values also. I know there probably are clinicians that get very upset when patients come in with their whole list of questions. And you know what? I look at it as we're in partnership. The more that I can teach somebody about how to manage their disease and their family and the better understanding they have about it, the more that they can interact and be active participants in how it is that we're going to manage this together. Because this is going to be a long haul. It's not just your clinician telling you what to do. Not if you're here. Not if you're a person that's involved and active. Yes?
Oh, I just want to interject, excuse me. Tina's presentation, as far as getting a copy, we cannot do that. However, her entire presentation will be uploaded on our website in 2 to 3 days. So where you can review that. So as soon as Jack uploads it, and he's told me in 2 to 3 days he thinks he can get it uploaded, I'll send out an email with our website, and you can view it that way at your own leisure, okay? And you don't have to go outside of our website too. It's viewable within our website, okay?
Any other questions? You guys have been great, especially listening to like pathophysiology with lunch. I mean, you are the smartest ones. Thank you so much. Thank you so much for inviting me. It's been an absolute pleasure.